Hi everyone, good morning. I'm Sinduri Golamudi. I am currently a third year resident in internal medicine in New York and thankfully a DCB Academy fellow. Um, so today we're going to be talking about myocardial perfusion injury. It paradoxically causes further damage to heart tissue following the restoration of blood flow after ischemia. Though reperfusion is necessary to salvage ischemic tissue, it can also induce damage through oxidative stress, calcium overload, and inflammation, leading to microvascular obstruction and myocyte death. We'll explore the underlying pathophysiology very quickly and then talk about diagnostic tools and the latest evidence for therapeutic options, including novel and investigative treatments. So the pathophysiology, the myocardial reperfusion injury arises from several key mechanisms. First being oxidative stress, which occurs when an influx of oxygen after ischemia leads to the generation of reactive oxygen species, which damages cell membranes and proteins. Calcium overload further compounds this issue as disrupted ion channels can cause hypercontracture of myocytes, ultimately leading to cell death. Additionally, inflammation is triggered as neutrophils are activated, releasing cytokines that worsen tissue damage. And then last but not least, we have microvascular obstruction, which results from endothelial swelling and platelet activation, which blocks the capillaries and prevents adequate reperfusion. And together, these processes explain the paradoxical worsening of myocardial function after reperfusion. We'll start with myocardial stunning as the first clinical manifestation. It's a very common feature where the heart muscle temporarily loses its ability to contract properly despite blood flow being restored. This is reversible but impairs immediate function. I don't know if my pointer is working.
Yeah, it's working.
Okay, perfect.
But
So
there's a black pointer. You mean the red one? The red one isn't.
oh, okay. Yeah, I don't know how to get my pointer to working, but basically, the picture that's labeled A, up at the top, it shows a vulnerable high-risk non-calcified plaque of the LAD with significant positive remodeling, which is what the white arrow in A is showing. And in B1, right underneath A, B1, it shows the acute complication of the atherosclerotic plaque rupture or erosion, causing the LAD occlusion. And you can see the consequent changes on the EKG on the left side, on the right side. And it shows ST segment elevations on the anterior precordial leads. B3 and B4, right below B1, is an echocardiograph imaging of the left ventricle in the diastolic and systolic phase. And the little arrowheads that are the black arrowheads right above 4 um, display the apical and mid-septal akinesis. And then up in C is where they perform a PTCA, open up the blocked artery, and allow the myocardium to remain viable. And now when we look at D, the one which shows myocardial stunning, you can see that cardiac systolic dysfunction still persists soon after successful coronary reperfusion. And E shows that weeks after the PTCA, the left ventricle mechanical function is back to normal. And this is what myocardial stunning is. So weeks later, they do recover, but immediately it does show systolic dysfunction. The second clinical manifestation, like we talked about earlier, was microvascular obstruction. This occurs when blood flow to the heart's smallest vessel remains restricted, even though the larger vessels have been treated. This is also referred to sometimes as no reflow phenomenon. So on the left side, it shows you all the pathophysiological reasons for why we do not have reflow. And the third clinical manifestation is reperfusion arrhythmias. It's an irregular heart rhythm that occurs when blood flow is restored to the heart muscle after a period of blocked or slowing. And they range from accelerated idioventricular rhythms, like the one up on the pink EKG, and PVCs, like the one on the white EKG, as well as VFib and VTAC and atrial fibrillation. And the fourth clinical manifestation we'll talk about is probably the most detrimental aspect of myocardial reperfusion injury. It's termed lethal reperfusion injury, and it's defined as myocardial injury caused by the restoration of coronary blood flow after an ischemic episode. The injury culminates in the death of cardiac myocytes that were viable immediately before myocardial reperfusion. This form of myocardial injury, which by itself can induce cardiomyocyte death and increase the infarct size, um, explains why, despite optimal myocardial reperfusion, the rate of death after an acute MI does approach 10%, and the incidence of cardiac failure after an acute MI is almost 25%. So the image on the screen shows myocardial ischemia in absence of reperfusion. So the infarct size is about 70%. And with reperfusion, it decreases the infarct size by 40%, but the pink area, which shows that the remaining 30% of the infarct is due to lethal reperfusion injury. But now with cardioprotection as well as abilities to decrease the lethal reperfusion injury, we're able to realize the full benefits of reperfusion and preventing the lethal reperfusion injury. So now we'll talk about diagnostic modalities. So it relies on different diagnostic modalities, one being EKG. So reperfusion arrhythmias such as VT or VFib indicate successful reperfusion, but can also suggest potential microvascular issues. ST segment resolution is a key metric to gauge the effectiveness of reperfusion. Incomplete ST segment resolution often indicates the presence of a microvascular obstruction. Cardiac biomarkers, so troponin and CKMB. Troponin, persistently elevated troponins post-reperfusion suggest ongoing myocardial damage. There's many studies. The one that's notable is Morrow et al. In 2001, shows that elevated troponin levels post-PCI correlate with worse outcomes. CKMB, though less specific than troponins, they can help track reperfusion injury dynamics. Third is the imaging techniques. Echocardiography, it's useful for assessing myocardial stenting like we talked prior. Speckle tracking echocardiography can provide insight into regional strain, helping to quantify the reperfusion injury. Cardiac MRI is the gold standard for identifying microvascular obstruction via late gadolinium enhancement. In a pivotal study by Nijvelt in 2008, MVO, microvascular obstruction, detected on the cardiac MRI was found to be a strong predictor of adverse outcomes. Last but not least, invasive techniques. So coronary angiography and coronary flow reserve. Coronary flow reserve is an invasive measurement that can reveal microvascular dysfunction, which standard angiography may miss. So we're going to talk about, I'll go through the trials for each of these pharmacological interventions on the next slide, but I just wanted to give a brief overview of exactly what these pharmacological interventions do. So to begin with, we can talk about antioxidants. So the N-acetylcysteine, this drug basically scavenges reactive oxygen species, and administration of NAC reduced oxidative stress and infarct size in reperfused myocardium. SOD mimetics, so superoxide dismutase mimetics, target oxidative stress directly, and it's shown to reduce infarct size and improve left ventricular function in animal models. Second is ischemic preconditioning. So this involves cycles of brief ischemia, which activates protein kinases, like the pathways like PI3K/AKT. And this protective effect is mediated by mitochondrial K-ATP channels, and it reduces infarct size. Post-conditioning, this strategy involves, it's applied after reperfusion is completed. It involves brief interruptions of blood flow to modulate injury, and this has been shown to reduce the infarct size by 36% in STEMI patients undergoing PCI. Anti-inflammatory agents, we use statins and colchicine on a regular basis. So statins have shown to reduce inflammatory response. So statin therapy post-reperfusion reduces infarct size as well as inflammatory markers. Colchicine's anti-inflammatory properties were explored in the Colcott trial in 2019. It demonstrated that the reduced recurrent cardiovascular events by targeting IL-1 beta and neutrophilic activation. Calcium channel blockers, verapamil and diltiazem, they reduce the calcium overload, preventing hypercontracture. So in the study by Schultz, they confirmed that the verapamil decreases infarct size and protects against reperfusion injury. Adenosine is another medication that can help prevent neutrophil activation and improve microvascular perfusion. The Amistad 2 trial demonstrated that adenosine given during reperfusion reduced infarct size in anterior STEMI patients. And last but not least, cyclosporin inhibits the mitochondrial permeability transition pore. It's called MPTP. It prevents cell death. The Circus trial in 2015 studied cyclosporin's role in reducing reperfusion injury in STEMI, though the results were mixed regarding its efficacy. So I'm not sure how many cardiologists truly do use cyclosporin in real life. I've never seen it be used, but maybe the other cardiologists on the call can comment. So the different trials that have been studied for pharmacological treatments, we'll start with the oldest and sort of go to the newest. Yellen and Baxter. So this was a trial looking at ischemic preconditioning. It was a randomized controlled trial that was done on STEMI patients. There were 60 patients, and it was patients that underwent STEMI undergoing coronary angioplasty for the first time. The endpoints were reduction in infarct size and improvement in cardiac function. This study's p-value was less than 0.01. So the important findings in the study were that the ischemic preconditioning activated the protein kinases, and it led to a significant reduction in infarct size during reperfusion. The second trial that we'll talk about is Zhao et al. It's about superoxide dismutase mimetics. Like we talked about, it was an animal model of myocardial infarction. It was 30 mice. The male rats were subjected to 30 minutes of ischemia followed by reperfusion, and the endpoints were reduction in infarct size and improvement in left ventricular function. P-value was less than 0.05. And they found that the SODs did effectively reduce oxidative stress and the infarct size, enhancing myocardial recovery. Third trial is the Morrow et al. For troponin. They saw that it was a randomized control trial. They did it on 1,000 patients with STEMIs undergoing PCI. And the inclusion criteria was that patients presenting with chest pain and ST segment elevation on the EKG, and they correlated the troponin levels with myocardial injury and outcomes. So the p-value was less than 0.01, and they found that elevated troponin levels were predictive of myocardial injury and adverse outcomes, underscoring its utility as a biomarker. The fourth one is the Tardif et al. For statins. It was done on 400 STEMI patients, and the inclusion criteria was that patients with STEMI undergoing PCI within 24 hours of symptom onset. The endpoints were inflammatory marker levels and infarct size. P-value is significant. Important findings were that the statin therapy significantly reduced inflammatory markers and infarct size post reperfusion and resulted in smaller infarct sizes after reperfusion. Stat et al. Is about a post-conditioning trial. It was done on 140 STEMI patients undergoing PCI. Patients with STEMI treated with primary PCI within 12 hours of symptom onset was the inclusion criteria. The endpoint was looking at the reduction in infarct size and improvement in clinical outcomes. And they found that they reduced the infarct size by 36%, indicating its effectiveness in mitigating reperfusion injury. And the last trial is about adenosine. It was by Mahaffey in 2006. It was also a randomized control trial done on 150 anterior STEMI patients. The inclusion criteria was the patients with ST elevation, the anterior leads, and undergoing PCI. The endpoint was looking at the reduced infarct size. So the administration of adenosine during reperfusion significantly reduced the infarct size compared to their control groups. Now we'll move on to mechanical therapies. And the first one we're going to look at is controlled reperfusion. So controlled reperfusion devices, like the intra-aortic balloon pump, they reduce myocardial oxygen demand and improve coronary perfusion. And I'll go through the trials that displayed these mechanical therapies. But in a meta-analysis by Ranucci in 2009, they confirmed that the IABP does reduce mortality in high-risk PCI patients, and devices that regulate the flow and pressure during initial reperfusion, such as controlled reperfusion catheters, have shown promise in animal models, but they are still requiring further clinical trials. The second is therapeutic hypothermia. Cooling patients to 32 to 34 degrees Celsius can reduce metabolic demand and limit myocardial damage. The Haka trial in 2002 demonstrated that the therapeutic hypothermia improved survival and neurological outcomes in post-cardiac patients, post-cardiac arrest patients, and it's now being investigated for broader applications in reperfusion injury. ECMO offers circulatory and respiratory support, reducing the cardiac workload in patients with severe myocardial injury. Research by ASO in 2016 highlighted ECMO's role in reducing mortality in patients with severe cardiogenic shock. And I know some hospitals around the United States are trying to also study ECMO with myocardial reperfusion. Ischemic post-conditioning. So mechanical ischemic post-conditioning involves short cycles of balloon inflation and deflation during the PCI. Like we spoke prior, it has been shown to reduce infarct size by modulating the myocardial response to reperfusion. So the different trials, the first one that we talked about was the Ranucci, the intra-aortic balloon pump. They used 300 high-risk PCI patients, and the inclusion criteria were patients with high-risk features such as cardiogenic shock or left main coronary artery disease. The endpoints were mortality and hemodynamic improvement. The p-value was significant for this study. They used IAPB in high-risk patients, reduced mortality rates, and improved hemodynamics during and after PCI procedures. In the trial ASO et al., where they used ECMO, in this, it was 100 severe cardiogenic shock patients and patients with severe cardiogenic shock not responding to conventional therapies. And they demonstrated that ECMO provided better survival rates and clinical outcomes compared to conventional therapy. And given this study, many have sprouted since then in terms of using it for myocardial infarction and STEMI patients for myocardial perfusion therapy. And for STAT et al., mechanical ischemic post-conditioning, we've already talked about this. So this was effective in significantly reducing infarct size to limit reperfusion injury. And Zhang's trial in 2013 was a RCT animal model. So it's 30 animal models of myocardial ischemia. It was male rats subjected to ischemia reperfusion protocols. So the controlled reperfusion techniques were shown to significantly improve myocardial recovery compared to standard reperfusion strategies. The Haka trial in 2002 is the therapeutic hypothermia. It was done in 200 post-cardiac arrest patients. And the inclusion criteria was patients who achieved ROSC after cardiac arrest. They looked at neurological and mortality rates, and they found that therapeutic hypothermia led to improved neurological outcomes and reduced mortality. There's some trials that are looking at therapeutic hypothermia in MI patients in terms of reperfusion, but those studies are still pending. There's a couple of studies that are under investigation that haven't come out as of cells. So they offer regenerative therapy. They secrete growth factors that reduce inflammation and promote angiogenesis. And there's a time trial in 2012. And while early results with the mesenchymal stem cells in STEMI patients were promising, they still need further trials to be able to confirm their long-term benefits. The second was a gene therapy. It's targeting protective pathways like NO signaling and enhancing mitochondrial biogenesis. There's a study by Hu et al. In 2015 where they demonstrated that delivering the VEGF gene therapy improved microvascular perfusion and reduced reperfusion injury in preclinical models. The third one is microRNAs, and miRNAs modulate gene expression related to apoptosis and inflammation, and it has shown promise in reducing apoptosis and fibrosis in experimental models. But uh, clinical studies haven't been done yet. For nanomedicine, nanoparticles can deliver drugs or gene therapies directly into the ischemic myocardium, enhancing targeted delivery. There was a study done by McCarthy in 2016 that demonstrated that nanoparticle-based drug delivery improved myocardial perfusion and reduced infarct size in animal models. So prognosis and outcomes, while early reperfusion is crucial for saving ischemic tissue, the degree of reperfusion injuries influences heavily the long-term prognosis. Patients with significant myocardial injury are at greater risk for heart failure and arrhythmias. Diagnostic tools like cardiac MRI can help predict outcomes, with factors such as infarct size and microvascular obstruction being critical determinants for long-term prognosis. Prompt intervention and appropriate therapies can improve outcomes, but we must remain vigilant to the potential for long-term complications. And that is my presentation. Any questions from anyone?
That was very nice and comprehensive. Thank you very much, Dr. Cindy. Um, if we can have the opinion of this,
I'm so sorry, Sarah, you're cutting off. I can't hear you.
so just
Thank you, Cindy, for the great lesson. Really,
Thank you.
great job, great job. I want to ask you, well, after this lesson and you study the argument, in your opinion, what is the the best choice in order to prevent mm, a reperfusion injury after during a myocardial infarction, in a point of pharmacological and invasive point of view? Your idea in general, in practice, when you have a patient.
So I've never truly seen it in the cath lab. I'm still only a resident, but I think possibly using pharmacological interventions like statins, adenosine to decrease the reperfusion injury in combination with preconditioning and post-conditioning, I think might be able to give us a better evaluation of the reperfusion injury. But I know in most STEMI patients that we've had in our hospital, we start patients on statins immediately. But I've never seen adenosine being used in our cath lab. But I think I've seen papers on IV adenosine and intracoronary adenosine. So I feel like
Yes, yes.
using statin and then either intracoronary or IV adenosine plus the post conditioning, I think might be the best approach at having a bit of each to be able to tackle the problem.
Yes, but practically you use the adenosine when you have no reflow or slow flow.
But what about adrenaline intracoronary? What do you think? No flow.
When you have no reflow.
Yeah, there are some studies showing that could be benefiting patients.
Yes.
Also, is there a difference between when you use the intravenous adenosine versus intracoronary? I know there's a little bit of differences in terms of inducing the hyperemia with intracoronary, I believe, more than intravenous, or is that more dependent on
But
the
in patients when we have STEMI patients,
Mhm.
we
You
think
use
about
intracoronary.
intracoronary instead of peripheral. Intravenous.
Okay. Um,
And what
sorry.
about mechanical thrombectomy? What do you think? How it look like in your hospital, in the cath lab? Do you
Uh,
use the
you,
thrombectomy when there's the big
you, are,
thrombus?
you are you are talking to me?
No, to all of you.
In general, you say. In general, you say. This is what I think. We know the indication on the guidelines, but what I've seen where I worked and where I am now in the United States is that in every hospital, everybody used the aspiration when the thrombus burden was high, independently from what the guidelines said. Because for every interventional cardiologist which I worked during my training, if there was a large thrombus burden, they immediately use the thrombo
Thromboaspiration.
use the
Mm,
thromboaspiration. Yes, I have, and a lot of situations in a lot of complicated PCI, mainly in large
all
right
right.
coronary artery, could be impossible without the thromboaspiration. This is what I think. Probably the the problem of the no evidence of beneficial effect of thromboaspiration is that it's complicated to find the correct endpoints in the clinical trial. Like this could be a problem. This is what I think.
Mm. So you mean that there could be some clinical endpoints? The problem with the endpoints in comparing with and without mechanical thrombectomy? Yeah.
Yeah.
All right. So thank you for those very nice lecture. It's interesting.